I'm very pleased to introduce Dr. Cassie Mitchell to you all today, and for her to have been willing to speak in our supergroup today. And so there are some of you, I think, that are not as familiar with the supergroup. This is a computational modeling and theory supergroup, combined collaborative group between several faculty in different engineering disciplines in chemistry and physics. And the thing we have in common is that we use computational methods to solve scientific problems. So Dr. Cassie Mitchell is coming from a different computational perspective than what most of us have been doing, but her work relates to some biomedical applications, and she is an alum of the OSU School of Chemical Engineering, where she earned her bachelor's degree in 2004. And she's here as part of our centennial celebration for our School of Chemical Engineering, which is happening today and tomorrow. After she finished here, she went to Georgia Tech / Emory, their joint program in biomedical engineering, and she got her PhD there. And then for several years, she was a research assistant professor, and just this fall, she's transitioned into a tenure track position within biomedical engineering. And so she also, so it's a joint department, biomedical engineering at Georgia Tech, Emory School of Medicine. And she's very interested in clinical translation from data at the bench side to bedside clinical practice and using data-enabled prediction. And so I hope she'll talk a little bit about her army of workforce, but she has a lot of students in her team and has done a lot with big data and computing. And she, on her free time, it's not really free time, she is a world-class athlete and has competed in multiple Paralympic Games and actually holds the world record in all the distances in her category for the sprint distances in track and field. And she's also competed in other sporting events at very high world-class levels. So she does not have free time. When she is down, not in office, not researching, she is writing proposals, a very energetic, very dedicated, persistent person. So I'm excited to hear your talk today and to hear more about your research. So thank you for being willing to give us a seminar today, Cassie.
Well, thanks, Ashley. And thank you guys so much for coming. I think it's awesome that you guys have a computational, what was it called, a pack?
Supergroup.
Supergroup. I call it a pack. Sorry. Politically minded, but I'm really not. Sorry, got that. But that's really neat, a supergroup, so that you guys can share ideas across different spectrums and integrate that. That's really awesome. It is my honor to be here today to talk to you about predictive medicine in general, but I want to use amyotrophic lateral sclerosis as our case study as some of the predictive medicine that my lab is doing. My laboratory is called the Laboratory for Pathology Dynamics, and as our little logo there implies, we do cellular work with data. We also have the computational aspect represented by the zeros and ones, and biochemical pathways, which is what most of you guys work with, mechanistic if you're in the biomedical world. And then we have the dynamic, which the gear represents, aspect of that, and truly systems dynamics, more like what you would see in physics or in engineering. And so our goal is to encapsulate all of those things and to see disease as a complex system and model it as a complex system, and from that you can get to personalized medicine. All right? All right. A little bit about me. Ashley told you pretty much everything you really need to know. There's a sign in my office that says never, never, never give up. That's kind of my motto in life. My family is important to me. They're pictured there with my medals, my parents. My students, I have an army of undergraduates that work for me, usually about 35 to 50 per semester. And they're like my family, and I really enjoy what we do in the lab, but also the mentoring. My faith is important to me, and I'm also a counselor at 5 different hospitals in Atlanta, where I help patients overcome the emotional and psychological stress of usually it's neurological injury or disease, but it can be other aspects as well. You get a diagnosis, and how do you overcome these things? So I call it the first principles because in engineering, we have to have our first principles that dictate our theory. So I feel like as human beings, we also have to have our first principles that dictate who we are, right? My career path, I was not always in a wheelchair. I grew up on a small farm in Warner, Oklahoma. I learned how to ride before I learned how to walk, and I had several world championships in Western speed events, doing what we call in Oklahoma rodeo, and I'm sure most of you who are from the Oklahoma area have been to at least one rodeo in your life. At 18, I was diagnosed with neuromyelitis optica, which is an autoimmune neurological disease that causes inflammation in the optic nerve, which causes vision impairments, and also in the spinal cord, namely the cervical spinal cord, which is your neck, which means I am impaired in all 4 limbs, which is why I have the wrist braces, and I'm paralyzed from the chest down, and then it impedes my arms, but it doesn't completely paralyze my arms. At 18, this happened, and I was supposed to go to some fancy schmancy pre-medical school, but I think my disability ended up being a godsend because I ended up at Oklahoma State instead, okay? I had a track scholarship to go to a pre-medical school, a private school, but when they learned I couldn't run, they wouldn't give me that scholarship. So I went to Oklahoma State on an academic scholarship, probably one of the best things that could have happened in my life. So I'm really thankful for the background that I got at Oklahoma State and the still like family here, and it's really an honor to be here. I worked briefly at ExxonMobil as a reservoir engineer doing thermodynamic modeling, trying to optimize how oil comes out of the ground. And then after about a year of that, I decided to go to graduate school for my PhD in biomedical engineering. I loved chemical engineering and the applications, but that was that part of me that still wanted that medical field. And so that's how I ended up at Georgia Tech and Emory. Emory is a medical school, so we have the access to clinicians and patients to do work. Georgia Tech is an engineering school, as the name implies. And so it's really a great mix to have a joint department where you have both that truly clinical aspect as well as the theoretical side. Athletically, briefly, just in case you're interested, I started when I was young in gymnastics, had competed at the state, would have been at the national level, decided I didn't want to go away and live on a ranch in Texas like a lot of our elite U.S. gymnasts do. So I stayed at home, became very good in track, and had that track scholarship, but unfortunately I was paralyzed. At Oklahoma State, in addition to coming to a great school with a great chemical engineering degree, I also got my athleticism back. It was here that I actually started Paralympic athletics on the OSU wheelchair basketball team. And that got me going, and I switched sports over my career. And also as my disease progressed early on, and when I was at Oklahoma State, my hands were not as affected as much as they are now. And as my disease progressed, I changed different sports, and in 2016, I got a medal at the Paralympic Games in Rio de Janeiro, and then I also have several world records. I feel like the athletics, and I think it's important for young career folks to hear that whether it's athletics or whatever your passion is, I think you need to have balance in your life, okay? So whether it's with your family, your friends, you know, a hobby, the more balance you have in your life, the better you're going to be in your career. You get more creativity, you get, you know, that extra spark of motivation. And so I'm guilty, like a lot of us, of spending too much time in the lab. That's true. But I try to remind myself that productivity and efficiency is important, but you've got to have that balance. And if you have the balance, then you will actually do better in your career. All right? So moving on to the topic of today's talk is amyotrophic lateral sclerosis. I know in 2014, probably some of you participated in what was called the Ice Bucket Challenge, where everyone across the country and across the world was dumping these buckets of ice water on their head. A lot of people didn't know probably why they were doing that, but it was actually to raise awareness and research funds for a disease called amyotrophic lateral sclerosis. It's a motor neuron disease, which means it affects the nerves that control your muscles. All right,
so
the one.
Lou Gehrig's disease?
Yes, sir, Lou Gehrig's disease. And so little is really known about exactly how the disease works. It's considered to be a multifactorial disease. And so we'll talk a little bit more about that today. This is my lab here. We dumped Georgia Tech President Peterson during the Ice Bucket Challenge, and you can see some of the army of people that work with me back there in that picture. I picked ALS not because I have ALS or because I had a family member, but rather there's just so little that was being done with ALS. There's only 2 FDA-approved drugs. There's no cure. And despite decades of research, we really haven't gotten as far as we should. And I wanted to be able to pick a field where I thought I could make an impact. So what better way than picking a field where there's hardly anything, right? So maybe that was too challenging, but that was my reasoning. And so, so here we are, we're talking about ALS. As the gentleman on the front row pointed out, it is also known as Lou Gehrig's disease. And it's mostly in the US. And Lou Gehrig was a famous baseball player that played for the New York Yankees. He was diagnosed in 1939 at the age of 36. Ironically, he was diagnosed by Dr. Charles William Mayo of the Mayo Clinic in Rochester, Minnesota. And to this day, Lou Gehrig's records still reside in Rochester. He died within 2 years of diagnosis, and sadly, the average time of death today is still about 3 years from diagnosis. So we haven't changed much, and that's not because we have curative treatments, but rather because we have palliative interventions, okay? So we can't slow, a treatment actually slows the disease, and an intervention intervenes to try and make, like sustain life, but you're not actually stopping the progress of the disease, all right? So a few fast facts about ALS. If you go to alsa.org, that is the ALS Association, you can read a little bit of fast facts. But essentially there's about 5,000 new cases of ALS per year. It's technically considered a rare disease, but at the same time it is the #1 motor neuron disease. More common among those of European or Caucasian descent. We don't see as much ALS in the Asian population. The average time of death is 2 to 5 years. Really, the median is about 3 years. Let's see, 2 FDA-approved drugs. One is called Riluzole. It's a sodium channel blocker. That's the #1 prescribed drug. It extends life by, anyone want to venture a guess? 3 months. 3 measly months. 3 months is a long time when you're a patient that's about to die, but I feel like we could do a lot better. The second FDA-approved drug has only been out less than a year. It's also another excitotoxic drug, anti-excitotoxic drug, but right now it's about 2.5 months on that one. They don't know if there's going to be a synergistic effect between the two, but the really sad thing is if you don't start either drug by the time, like within 6 months of your first symptom onset, then neither drug has an effect. The type of symptoms that patients have, most people present with what is called limb onset, which means that they have weakness or paralysis in an extremity, your leg, your arm. There are another about 15 to 20% of ALS patients get what is called bulbar onset. So bulbar is after the pseudobulbar portion of your brain that helps control speech and swallowing and facial muscles, all right? So they may be able to walk perfectly fine, but they have dysarthria is the technical term for it, with a speech impediment, where they know that their speech is incorrect, but because of the control of their facial muscles and all, they can't correct it. Like 2% of patients have a respiratory onset, meaning that the innervation to the diaphragm is impaired, and so they lose control of their voluntary respiration, which obviously is not good, right? Most patients don't die from the paralysis, but rather due to secondary to respiratory complications, whether it be, in the middle of the night, losing the ability to breathe while they're asleep, or, pneumonia or other types of respiratory complications. So dysphagia or trouble swallowing, trouble speaking, walking, trouble grasping, and breathing, trouble breathing, those are the main symptoms. There's no straightforward diagnosis for ALS. It's called a disease where you have to what is the word here? You have to exclude, diagnosis of exclusion, all right? So you exclude other diseases, and if you don't have MS, you don't have Parkinson's, if you don't have one of the other diseases, then you likely have ALS. So they do MRI, blood tests, and electrophysiology of the muscles, and if they determine you don't have demyelination and you don't have a lack of dopamine, which is what Parkinson's is caused by, then you probably have ALS. So you kind of have to watch. Well, that's bad, because if you're waiting to see what's going to happen and you haven't started treatment, then you get bye-bye your 3 months of extra help with Riluzole. All all right? There is an increase in vets that have it. We think that's due to chemicals like Agent Orange and some of the other exposures that they have, but we're not really sure.